you're working in CT or interventional, they're starting to require employees do that so that you're familiar with that. It's important. Radiation-induced skin injuries. People always say it doesn't happen. We know it does. Joint Commission several years ago implemented a requirement that if you have any exam, fluoroscopic exam, where a single field receives more than 1,500 rads or 15 gray, it has to be investigated. You have to look at that and figure out, why did that patient get that amount of skin dose? And of course, we have been through all these before. Your threshold dose, which would be 2 gray for early transient erythema, approximately 3 gray for temporary epilation, 6 for main erythema, permanent epilation, 7 gray, occurring within hours to weeks. Usually, this is a usual fluoro dose rate of 2 rads per minute. Still use rads for fluoro dose because that's what how the state measures. What can I say? So this would be a high dose rate. Very rare that you're using 20 rads a minute, but this is very common. 2 to 4 rads a minute is typical fluoro doses. Okay. Then you have dry desquamation at 10 gray, invasive fibrosis at 10 gray, 11 gray dermal atrophy, telangiectasis at 12 gray. These are approximate. You might have a patient that's more sensitive, others that are more resistant. Then you go all the way up to ulceration. I used to include pictures, but everybody got upset, so I took the pictures out. So, some of the things you want to consider before performing fluoroscopy on a patient. If the patient has ascites, you want to drain, especially before a TIPS procedure. Physicians should obtain a thorough medical history. Has that patient gone through these exams before? The reason is, if they've had multiple exams of the same type and they're going through the same area of the skin, we talked about repair, but if someone's really sick, they could have multiple procedures within a week or two that they're in the hospital, in which case you do have to be concerned about exposures adding up. Okay. If a previous radiation history exists, examine the patient for signs of skin changes and try to avoid added irradiation as possible. This is what the physician should be doing when they're talking to the patient before the exam. Most physicians, honestly, aren't doing it. Want to review the medical history for conditions that might increase radiation sensitivity, and there's a lot of those. Collagen vascular disease, particularly scleroderma, discoid lupus, erythematosus, and mixed connective tissue disease, diabetes, hyperthyroidism, ataxia telangiectasis, sensitizing chemical pharmaceutical agents. Anybody on tetracycline? You don't want to spend a lot of time in the sun because you're going to get more easily sunburned. Same thing about having x-rays if you're on tetracycline. It makes your skin much more sensitive. There's a whole bunch of different conditions. You want to consider including the potential for skin injury and the patient consent. This is really important for interventional procedures if you're doing any of those, especially if the patient's large or the procedure could be prolonged. You want to at least mention the possibility if your skin turns red, it will go away in a certain period of time. You might want to call your doctor. I mean, there's a lot of things a physician can do to prepare those patients. Counsel the patient about those and other risk factors. Okay, radiation safety for X-ray sources fluoroscopy. Interrupted use of fluoroscopy pedal. You want to monitor fluoro time. What's the typical time before you get the buzzer on a fluoro?
5 minutes.
5 minutes. Has to be reset, has to be audible. Okay? Provide lead apparel, not just for the patient, if gonads are included, but for you folks as well, for the physician. Collimate to the area of interest. Use portable or hanging shields when possible. Wear your dosimeter correctly and periodically review doses. Where do you wear your dosimeter?
Next to your thyroid.
At the collar, outside the apron. If you are pregnant, where do you wear your dosimeter?
Underneath your last.
How many do you have?
2.
2. One underneath the apron at the waist and one at the collar outside. Okay? Step back or leave the room when possible. Now there's some things to help with that. There's some monitoring devices that you can actually wear. It does not measure, does not record exposure. What it does record though is whether you're in a green, yellow, or red zone. Those zones are set up in the device, and as you move around the room doing the things you need to do, you can look up at a display and you'll see your badge reading go from red to orange, yellow, and green. And it's a great learning tool because that helps you know what kind of scatter is going on in that environment, so you know where you can walk safely, where you can stand safely and keep your exposure as low as you can. Okay? And you want to use appropriate equipment settings and techniques. Minimize the air gap between the patient and the image intensifier. Use a practical maximum source to skin distance. Largest field of view practicable. Physicians should never be using mag mode unless it's absolutely necessary for them to see some part of the anatomy that requires it. Be sure physicians are properly trained in the clinical performance of the procedure. I guarantee you, I don't care what hospital it is in anywhere, this doesn't happen very often. A lot of times when you get a new surgeon that's been hired, the experienced surgeon that mentors them will say, well, for doing this procedure, okay, the tech brings the C-arm in, and they're going to set this up, and then you step on this, and your image is up there, and you're good. That's not training. When I lectured to residents when they were new, what I told them to do is find the most experienced technologist that works in surgery and have them teach you how that C-arm works. Have them show you all the bells, the whistles, the dials, how it works, how it drives, what they need to know how to do, because you folks are the expert. It's very rare to find any physician that would be an expert at knowing how the equipment functions. You folks do, because you're going to be using it every single day. Okay. Rule of thumb is if fluoroscopy timer has to be reset more than 6 times. Usually in some facilities it might be 6 times, might be more than that, but there should be something, some sort of protocol that allows them to make note of that, for the chief of service perhaps to take the physician aside and say, okay, why are you using so much fluoro in this procedure? You will find in your facilities some of, especially the younger radiologists that are hired, are really experienced, and they get a lot of the really tough cases. So a lot of folks think, oh, well, the new radiologist has these really long fluoro times because they don't know what they're doing. No, typically it's because they get the difficult cases nobody else wants to do. So that's one of the things you need to think about if you're monitoring physician exposure. And I'm telling you this because in your smaller facilities, the radiation safety officer in some facilities is a technologist. It happens. Be prepared. Okay, consider changing beam angle to another skin site to avoid over-irradiation. Use dose-limiting procedures and features. So you got variable pulse fluoroscopy, software-controlled copper filtration. Avoid direct entry site irradiation of the female breast. It's very important. Ensure that arms are not present in the beam path. Acquire some sort of real-time dose monitoring to ascertain patient risk So risk-benefit decisions can be made, mitigation implemented. The feds required, under the manufacturing practice, that every fluoroscopic piece of equipment manufactured after, I think it's 2006, has to have a display of either air kerma or dose area product, and we'll talk about that in a little bit. And if not, you want to consider purchasing new equipment with dose-saving features. So how do we monitor real-time dose parameters? We've got fluoroscopic time, typical and maximum exposure rate, dose area product, dose at a reference point, and skin dose mapping. Now the problem with fluoroscopic time is basically the whole intent of that was just to let a physician know that time has passed. Physicians get so involved with stuff, you needed a timer and it went off, gave you an audible signal so the physician knew, oh, really? 5 minutes are up? Really? Oh. Provides no information about dose rate, ignores fluorographic contributions, and ignores beam's entrance points. It's basically a timer. How many times do you have to reset it? Typical maximum dose rate, well, some people use that, but that's not really good. If you look at the KVP ranges between fluoroscopy and Cine, for example, Cine is mostly down in this region, KVP-wise. Fluoroscopy is at a whole different end. So your typical dose rate, measured with 7 7/8 inches of lucite, is really kind of meaningless unless you know and make a guess how much time was fluoro, how much time was fluorography, whether it was Cine or just digital. Okay? And dose rate varies with field size. So now you have to measure multiple things and then make some guesses. Dose area product was implemented by the feds. It's really kind of slick. Integrates dose across the X-ray beam. There's actually a detector in the collimator. Measures, as I said, measures the exposure coming out of that tube. It's easy to measure. Accumulates everything: fluoroscopy, fluorography, radiography. It does not provide direct indication of skin dose, however, and it overestimates skin dose when the beam is moved to multiple locations during the procedure. So it's kind of like a hose filling a pail, okay? Regardless of where the pail's moved, you've still got the hose filling it. So you have no idea what part of the skin is being exposed. The dose area product also goes geometrically based, So the dose area product for a large field, low skin dose is the same as for a small field, high skin dose. So that makes it difficult. Best when it's used for quality assurance and quality improvement programs. Since it's based on geometry, in order to use it effectively and try to make a guess at patient skin exposure, you need to know the field size where the X-ray beam enters the patient's skin. If you do that, you can do some math and get a rough approximation. Better is dose reference points, what we call air kerma. Okay. Of course, that depends. The piece of equipment, it's either international or US. And the point of measurement differs. So for a US piece of equipment, it's mostly what you're going to use. At minimum SID, air kerma is measured 30 cm from the image receptor. Okay. For European, it's the ISO center at a fixed source to axial distance. The problem you can see is for the thin patients, it's measured at different points. You can underestimate or overestimate, but air kerma is still the best way to estimate patient skin dose. And the nice part of that is, remember, for X-ray, everything is a factor 1. So 1 gray of air kerma equals 1 gray of dose equals 1 gray or 1 sievert, because it's X-ray. It's when you get into different particulates, then it's different. So that's probably the best way to estimate based on current technology. This should all be reflected in the console display for your fluoro, especially your special procedures rooms. So these are kind of your different geometries. You can have a fixed SID. You can have a fixed SID and a variable distance between cable and image receptor. And you've got a fixed SAD, source to axis. This is just to show the effects of patient size depending on what method you have. Notice the image receptor is going to get the same amount of exposure because the image receptor says, I need X amount of exposure to make a decent image. So your thin patients, of course, have got greater distance here, so the entrance exposure to the skin is going to be less. Your heavier patients, skin is closer to the tube. Same thing here. And then, of course, you're measuring to the middle of the patient. So if this distance is small, it's pretty close, but for your large patients, your distance is measured somewhere else. So it doesn't reflect skin. So you have to kind of know your system. Skin dose mapping is the best way. Siemens actually had a system, probably 30 years ago or more. Basically, used the patient height, weight, table position, model the shape and location of the patient's skin surfaces, calculates what skin patches are irradiated, and the corresponding dose rate. And it maps the skin isodose curve, and it's like making an incision on the patient and peeling them up open, and you can see where that is. It includes fluoroscopic, fluorographic, and radiographic doses. Excellent. Problem is, when it was first put forth, it was very expensive. Computers were still pretty new. Software was very expensive. People didn't buy it. It went away. There are now companies that are looking at bringing this technology back, which would be great, and I look forward to seeing it. NCRP report number 102 talks about protection for equipment design, performance, and use. Room shielding. Between the state of California regulations for exposure, radiation exposure to uncontrolled areas, and the building code in Title 24 specifies that you need to have shielding for any piece of X-ray equipment in order to bring the exposure to uncontrolled areas outside down to a point that is within legal limits. Okay. And for California, for uncontrolled areas, public areas, that would be 2 MR in a week. Okay. So you base it based on what the weekly exposure levels are per room. How is that room used? What kind of procedures does it use? How many typical minutes of fluoro? At what typical KVP? Occupancy factors. Use factors. How often is the tube pointed to the floor? How often is it pointed to the ceiling? Workload. How many MA minutes per week typically are done? And at what tube potential? Take all of these factors, you have a room layout, you have measurements, and you can actually physically design how much lead goes in particular walls to protect the folks next. I hated doing these things. It'd be a royal pain in the tush. This is where the building code comes in, building requirements for shielding the X-ray facilities, shielding requirements for diagnostic X-ray and radiation therapy treatment rooms, and the requirements for control booth barriers and primary barriers. Primary barriers, anything where the X-ray beam is pointed towards a barrier. So in this room here, for example, where the wall bucky is, that would be considered a primary barrier. So this wall would be shielded much differently than the rest of the walls. For the rest of the walls, the tube's pointed to the floor, so the shielding for the surrounding walls would be less. Okay, nobody's there yet, that's good. Okay, do some review questions, then we'll go through pediatric. Pediatric is really fast, I think there's like 6 slides. Let's get this done first. By regulation, when is a patient considered to be overexposed? How many say A, likely to receive annual effective whole body dose limit for occupational personnel? B, if they receive more than 1,500 rads to the skin in a single fluoroscopy field of view. C, there is no regulatory limit on patient exposure. D, none of the above. How many say A? B?
D.
C? D? Correct answer is C. There is no limit on patient exposure. I know, I find that kind of hard to believe. There's limits on what you can be exposed to. And if you go over those limits, there's all sorts of things that your radiation safety officer has to do to investigate, find out what happened, and put something into effect to prevent that for future.
Shoot them hot.
But I can take a patient, I can put them in front of a board and shoot chest x-rays one after another, after
Shoot
another,
'em
after
hot.
another, all day. Now, what stops that are things like words called malpractice, things. But there is no regulatory limit on patient exposure. It's up to the radiologist to determine what is appropriate. Okay. Next question. By regulation, which of the following situations requires the use of shielding for a patient? During fluoroscopy, when the gonads are in the direct beam and diagnostic quality is not compromised, in areas where the exposure rate may be 5 millirentgen per hour or more. D, when patients request it.
B.
A, B, C, D. When gonads are in the direct beam and diagnostic quality is not compromised. Compromised, spelling. Keywords, regulation, requires for the patient. That's the only time that it is required under regulation. Okay? Now, it could be said that you can kind of go beyond that because with the implementation 10 CFR Part 20 over X-ray, that says the hospital has to have a radiation safety program. And as part of a radiation safety program, you have to have protocols in place that specify when and under what situation patient shielding is used. Okay. But currently, under regulation only requires it when the gonads are in the direct beam and diagnostic quality is not compromised.
So just any patient gonads on direct? Not
Patients of childbearing age. Now, what is childbearing age? I just read in the news not too long ago, 57-year-old female had a child. I think it's one of our movie stars or singing stars or somebody.
Isn't it Janet Jackson?
Yeah. Who's that?
We don't have time to watch that.
And men? Men can father children, there's on the record, into their 80s, 90s.
That is disgusting.
Get some
So
ground up.
childbearing, where it becomes touchy for you folks, is where does childbearing age start?
12.
You have to ask after 9.
You have to ask. Every facility has their own definition.
After 9?
Yeah.
If you get your
That's
period
all right.
really early.
Okay, there's all sorts of reasons for that I've seen published.
Yeah,
When I was a
have fun asking that
technologist,
question.
it was 15 and above.
I could deal with
dropped
that.
to 12, dropped to 10. The suspicion is that there are so many hormones in some of the meat, the beef, the pork, and the chicken that we consume that over time, male and female children are developing faster. The youngest reported pregnancy I've seen from an ER was at age 8.
That's disgusting, dude.
Was she pregnant?
I had to reread that particular article twice because I didn't believe it. Okay. Diagnostic X-ray. The typical lead apron made of 0.5 millimeter lead equivalent attenuates approximately, this is going to be a guess for you folks since I didn't discuss it. What do you think it does? 10% of the incident, 50% of the incident, 85 or 95? How many say A? 10%? 50%? 85%? 95%?
Damn, we're smart.
95%.
Well, that's good.
0.5 millimeter.
She's like, feel better about my job already.
Gotta stop and think about the math.
Okay.
What comes out of the tube through the patient to the receptor is about 1%. So about 1% of what comes out of the tube actually makes it through the patient. Of that, 1 to 3% exit as scatter. And of that, 95% of that is absorbed. Now, can this be carried too far? Now, the regulations say you have to have at least 0.25 millimeter lead in a room where the fluoro is being performed and the exposure rate is 5 MR per hour or more in the room. Typically, hospitals are now, almost everybody's using 0.5. Okay? However, there have been cases of people being very nervous. There's a female radiologist that I'm familiar with who was worried about exposure. She bought a 1 millimeter lead equivalent wraparound apron, or actually skirt, and a vest.
Wow, that's heavy.
And after about 6 months of heavy use, she had a problem with her back.
Yeah.
She received very little radiation, but she had a tremendous back injury from the amount of lead. So you do have to weigh protection versus weight and make some intelligent choices. By regulation, a gonadal shield must be 0.25 millimeter lead equivalent, used on every patient, evaluated annually for rips or tears, at least 0.5 millimeter lead equivalent. By regulation, A, B, C, D. Excellent. Now, by regulation, however, Joint Commission will require you to show them records, not only for inventory of your lead apparel, but how often it's tested and what the results are. And, I may have to change this slide, under the new state of California regulations where 10 CFR Part 20 includes X-ray, they specify radiation safety programs need to take into account those types of things. So your county inspectors are going to ask this question even though it's not specifically in regulation yet, but it's coming. Okay, by regulation, typical patient fluoroscopy skin entrance exposure must be less than 5 MR per minute, 10 MR per minute, 5 R per minute, 10 R per minute. How many say A? B? C? D? Now, let me specify. For your ASRT, it's 10 R per minute in automatic brightness mode, 5 R per minute if it's manual fluoro. However, in California, so you know, California requires 5 R per minute based on 7 7/8 inches of lucite with a maximum of 10 R per minute, maximum of 20 in high mode. Okay? But for ASRT, it's 10 and 20. Okay? So you do have to keep those different. Okay? What percentage of diagnostic X-ray beam get through a typical patient abdomen to the X-ray film? 1 to 2%, 5 to 10%, 20 to 30%, at least 50%. I think we talked about that. 1 to 2%. And of that, a very small fraction comes out as scatter to you. Which of the following is a rule of thumb regarding scatter exposure? Scatter exposure rate, 1 meter from the patient, is approximately 0.1% of the patient beam skin entrance exposure rate. Scatter is most intense at 90 degrees from the beam direction. Scattered X-rays are much lower energy than beam X-rays and therefore are less penetrating. Scatter X-rays occur toward the X-ray film. How many say A? B? C? D?
It's A or C, yeah.
Back past couple of slides, I've talked about scatter exposure rate, 1 meter from the patient is approximately 0.1% of the patient beam skin entrance exposure rate. Okay, so if it's 5 R per minute to the patient's abdomen, 1% of that is what? 0.05, so that's 50. That's 5,000. So that's 50 MR, and then another 1% of that. Not much. Any questions? Okay, let me pull up the pediatric really quick. Okay, children are much more sensitive. We already know that.